Hello, everyone. Welcome to this month's Simon Says Expert Series. I am Dr. Nawal Kassem. I'm a breast oncologist and I'm the physician lead for a cancer predisposition clinic where we take care of patients who have a genetic predisposition to cancer. Joining me today is my colleague, Cindy Hunter, aka the DNA Whisperer. Cindy has been doing this for a very long time. She's helped a lot of families understand their hereditary risk and the implications. So, Cindy, can you kind of kick us off and start talking to us about what genetics is and how that applies to people?
Certainly. Well, hello, everyone. So we're going to start with just a brief review of DNA. So there's a slide up here that shows that DNA is a molecule. It's in nearly all the cells of our body. It contains the instructions that make us human, give us our characteristics, keep our bodies working properly. It's currently estimated that our DNA consists of about 21,000 genes. Or we don't know, or we do know maybe about 5,000 of these 21,000 genes. So there's still a lot we do not know about our DNA. Our DNA is contained on structures that we call chromosomes. And you can see a diagram of the chromosomes in the upper left corner. And you can see that they come in pairs, which is important when we talk about inheritance. Now, there's a very few number of genes that are on our mitochondria DNA, but that's not important for us today. So when people say they have a cancer gene, it's not quite accurate. We all have the genes that we will be talking about. The question is the gene working like it's supposed to? So a mutation just means there's a change or a typo in the gene that causes that gene to malfunction. All right, so, oops, is that going to work? I'm trying to switch my slide. There we go. Sorry about that. So, how much cancer actually is hereditary? And this is actually a common misconception that I come across. Most cancers and tumors that develop are not related to inheritance. Now, you might come across numbers like this: 70 to 80% are sporadically occurring. And for the most part, that's probably a true, accurate estimation. I will note that there are some rare tumors and cancer types where we see a much higher likelihood of hereditary disease. And likewise, there are some cancer types where we rarely see inheritance. But in terms of the common cancers, thinking like breast cancer, colon cancer, probably around 80% or so are thought to be to be happening by chance. So generally, cancers that are happening by chance are developing at typical ages. So again, kind of think breast cancer, colon cancer, ovarian cancer, generally occurring after the 50s. And if we're not seeing a clustering of cancer in the family, it's more likely to be a chance occurrence of the cancer. So what are the clues for inherited risk? Age is actually one of the primary factor. If the individual is diagnosed with their cancer at an unusually young age, so kind of think, colorectal cancer, a kidney cancer, a breast cancer being diagnosed in the 20s or the 30s, that will raise a concern for hereditary disease just based on age of diagnosis. Now, we also take into account their personal medical history, including have they had any other types of cancers. So for some individuals, they might have a history of two separate cancers that developed unrelated to each other. So for example, maybe a breast cancer, and then 10 years later, they had a colorectal cancer. But we also can see features in the medical history that are not tumor or cancer related. So for example, we sometimes see benign tumors with some of these hereditary conditions, or other physical features. So as an example, if I'm meeting with a woman in her early 40s with breast cancer, and we go through medical history, and she tells me, oh, I've had this multinodular goiter, and my head seems to be really large. I can't wear hats. Those are features that, in addition to her breast cancer, are going to make me concerned about a certain genetic condition. So we really do take the person's medical history overall into account. The type of cancer is kind of think pathology or the histology type of what are the details of the cancer diagnosis. Probably the most common example is ovarian cancer. So there are different types of ovarian cancer that can occur, and not all of these are related to the inherited conditions. So probably the more common type of ovarian cancer, which occurs in older women, we can see in relation to hereditary mutations of BRCA1 or BRCA2. But there is an uncommon type of ovarian cancer that can occur in women in their 20s. And that type of cancer does not relate to BRCA1 or BRCA2. And we would actually think about other genetic conditions as possible explanations. So if you're meeting with a provider for genetic evaluation and they ask you questions about the cancer in the family, it's because it's the details of those diagnoses that really help us come to a better estimation of what may be going on in the family and likelihood of a hereditary mutation. Now, of course, we look at family history. So if you're seeing the same cancer or related cancers in the family in the same lineage, that of course will raise concerns. So again, as an example, if I'm meeting with an individual and he says my brother, my paternal aunt, and my paternal cousin and paternal grandfather all had colorectal cancer and they were in their 40s, that's obviously very concerning for hereditary conditions. But if I meet with a woman and she says my maternal grandmother and my paternal grandmother both have breast cancer and she's concerned, we actually are not, because paternal grandmother and maternal grandmother represent different biological lines. So we're not going to be as concerned in that situation. Now, I will note, on occasion, mother and father might be biological relatives, so that could change things. So if you meet with a geneticist, they will ask that question. Next, if we're seeing 2 or more occurrences of rare or uncommon cancers in a family in the same lineage, that will raise the concern for hereditary conditions. And then lastly, ancestry is important. Probably in the US, the most common example of this are individuals and families who are of Eastern European or Jewish ancestry. It's a population group that we know has a higher frequency of certain mutations relating to cancer risk. So that's all of the information that we take into account in determining should we be concerned for a hereditary condition in this individual or family. So then the next question is, what is genetic testing? So genetic testing for hereditary purposes is generally done on a blood sample or a saliva sample. And the goal is to try and determine, is there an identifiable genetic risk factor for the cancer that's occurring in this individual and family? And that in turn will then help with management for that individual and other family members in terms of what cancers are we concerned about, when should we start screening, and things like that. Now, genetic testing has a number of limitations. The first is we don't know all the genes involved in cancer risk. I mentioned earlier, we know maybe 5,000 of our 21,000 genes. So there's a lot of information about our DNA that we do not know. I certainly meet with families that clearly have hereditary disease for cancer, but genetic testing hasn't identified the underlying cause. And even within the genes that we do know about, we don't necessarily know completely well either. So this has resulted in kind of what we call the most informative approach, where if I'm meeting with an individual who is concerned for their family history of cancer, part of the assessment is who is the best person in the family to have genetic testing. Because again, if the goal is to get a better understanding of why cancer is occurring in that family, we want to test the people in the family who've had that cancer, if we can. We know that that's not always possible. But to kind of walk you through that a little bit more, so if I'm meeting with an individual and she tells me my mom and my maternal aunt both had breast cancer in their 40s, um, the most informative approach would be to start with genetic testing in the mother. If her genetic testing finds no hereditary mutation, then we know that for the patient, there really isn't a role in genetic testing to help establish her risk. But we're still going to screen her more carefully because she does have a family history, but we just don't know what's causing that family history. Now, if the mother has a hereditary mutation identified, then we've gained more information. And in that case, our patient could undergo genetic testing to see if she inherited it. And if she didn't, that's what we call a true negative. She does not have that same mutation that her mom has. And therefore, her risk for breast cancer is not going to be as high. Now, to contrast that, if I were to just go ahead and test that unaffected woman based on family history, and her genetic testing is negative, meaning we did not find any hereditary mutations, that really doesn't give us a lot of information. It's what we call an uninformative negative. She has a family history, but we don't know the cause of that family history. So again, if we can, we start with an affected family member if possible, just because that person their result gives us most information. Now, other limitations with genetic testing is even within the genes that we know, we don't necessarily know everything about them, and we do get indeterminate results. So on the report, you may see the words variant of unknown significance. So they found an alteration in the gene, but we just don't have enough data to say whether it causes a problem or not. So we treat these like negative. We're not going to alter a person's medical care based on a variant of unknown significance, and we're not going to recommend changing medical care for family members either. Now, there are definitely other implications that go along with genetic testing, not only for the individual, but also for the family. So for an individual found to have a hereditary mutation, it documents a moderate to highly elevated risk for developing cancer. It really depends upon the gene. And we're going to start screening at a younger age, and the frequency of screening may be increased. And that can be difficult information to become adjusted to. Some people have difficulties with that. For someone who's been through cancer once already, to find out that they have an increased risk for another cancer that's unrelated, could also have some emotional implications. The other part of this is the family side. So if we do find a hereditary mutation, it documents this is inherited. So we're going to be concerned about children, brothers and sisters, half siblings, parents, aunts, uncles, and cousins. So it really starts to branch out. And I've had some people tell me, express, uncertainty, a sense of burden. How am I supposed to share this information with people in the family? On the other hand, I've had people tell me it's a gift of information. But it definitely goes hand in hand with genetic testing and finding a hereditary mutation. The conditions we work with primarily follow what we call autosomal dominant pattern of inheritance, so it's going to affect every generation. With respect to children, most of the genes that we work with result in screening starting in adulthood. So we do not recommend testing children under the age of 18 for these mutations. Several of the conditions we work with do result in screening in children, as children. So in those cases, we do talk about predictive testing for minor children. Again, being a parent, right, that opens up a lot of emotional aspects as well. And the last part I wanted to touch on was the kind of the societal aspects, right? Insurance is a common question. Most medical insurances cover genetic testing if it's medically indicated. There are some concerns about would insurance misuse genetic information. There is a law that went into effect. It's called GINA. It's GINA, Genetic Information Non-Discrimination Act. It prohibits the misuse of genetic information by most medical insurers and employers. There are some groups that are not covered by GINA. There are, however, no laws regarding life insurance or disability policies. So I've had some people who've decided to postpone genetic testing because they were interested in having those policies in place. Again, that's a very personal decision. People have different perspectives on the value of those policies, but that is something to consider. All right, so now I'm going to switch over to Dr. Kassem, and she'll give us her thoughts on and perspectives.
Thanks, Cindy. So I think what's important to know here is that genetic or having a hereditary risk for cancer is not destiny, right? So it's important to note that if you do have that information, you can actually do something about it. So for a person who has a cancer diagnosis and is undergoing treatment, knowing that they have a genetic mutation can actually change or open up other treatment options. And that's something they can discuss with their oncologist. More so after diagnoses and treatment for many of those patients, they will at some point go back to their typical screening, right? So having colonoscopies and mammograms. And so having that genetic risk knowledge can help us get them on a screening program where if another cancer were to develop, it's caught early. And then, of course, importantly, like Cindy mentioned, knowing that you have a genetic risk for cancer allows us to identify those family members who may also have that same risk. And in their case, they would be, again, hopefully enrolled on a program where they would undergo more screening. They can have a discussion on whether surgery to reduce risks for cancer is appropriate. We also can offer things like chemoprevention, where, for example, I'll speak about breast cancer risk reduction. For example, tamoxifen is known to reduce risks for breast cancer and can be offered to patients if appropriate. And of course, discussions about lifestyle it becomes extremely important. So I suppose we're trying to encourage people to not be afraid of knowing their risk. If there is a significant family history and you're curious, talk to your provider. And it's very important to gather as much family history as possible, at least as it relates to your first and second degree relatives. Cindy, do we have a lot of questions that we can address at this point?
Well, I think we could talk a little bit about moderate risk versus high risk genes.
Yeah. Go ahead. And then I also want to touch on the clinic that we have also, but go ahead
Okay.
and talk about moderate risk genes first.
So I'm going to kind of contrast moderate risk and high risk genes. So the high risk genes are, you may have heard about BRCA1 or BRCA2. There's also two genes with Lynch syndrome that are considered high risk. And essentially a high risk gene mutation means that the lifetime risk for developing cancer is pretty high, generally greater than 50% over a lifetime. And oftentimes the cancers are developing at younger ages, so kind of 20s, 30s, and 40s. So you tend to see that classic pattern, one generation after the next, having affected individuals in the family. And we know now that in those families, if an individual inherits the high risk mutation, they have the associated cancer risk. But if they don't, then their risk for cancer goes back to general population level. Now, we've known about these genes for almost 30 years now. So the genes I mentioned were first identified in the early mid-1990s. Now, moving us forwards to about 2013, so 10, 11, 12 years ago now, our genetic testing technology changed as well as our knowledge, and the ability to do multi-gene testing became available. And this has resulted in more people being identified with these moderate risk genes. So a moderate risk gene, and some examples would be CHEK2, ATM, RAD51C. So these relate to more of a moderate risk for breast cancer or ovarian cancer. And we know that these mutations confer an elevated risk for cancer, kind of more in the moderate range, which I know is very vague. Kind of think with breast cancer, moderate risk is going to be like 20 to 35% over a lifetime. But we also know that the risk that mutation is not the sole reason why the cancer is developing. We know that there are other factors. It could be other genetic factors. It could be environmental. It could be lifestyle. We don't know. And it is more difficult to predict who might test positive for a moderate risk gene because you don't necessarily have a clear family history, and we don't know what all goes into the risk of cancer developing. And one of the challenges is that if you look at the data for CHEK2 as an example, 10 years ago, what we were telling people is different than what we're telling people nowadays. And so it actually is one of the reasons we started the program, which Dr. Kassem will now talk about.
All right. So, right. So this program, the Cancer Predisposition Management Clinic. So Cindy and I both started this program 3 years ago now. I'm looking at Cindy, I think 3.5 years ago now. Um, the goal really is to provide a home base for patients who are identified to have a genetic risk for cancer. So I would say almost all of our patients have already undergone genetic testing, have been informed of a genetic mutation that increases their risk for cancer. Their first appointment tends to be extremely long because many of my patients end up seeing Cindy first. They go through the family history, identify other family members who need testing, and then I can let Cindy talk more about that later. And then I meet with the patients, and like Cindy mentioned, not all risk is equal. You have the low, moderate, and high risks. So I go through the implications of the genetic mutation that they have. We talk about their estimated risk. We talk about ways we can help reduce that risk. For example, for breast cancer risk, we talk about the addition of an MRI to a mammogram. We do physical exam twice a year for many. We talk about the potential use for chemoprevention. Um, and for many patients, we also talk about, for example, doing more colonoscopies if applicable. Uh, Another option would be doing surgical resection to reduce cancer risks. So we cover a lot. We also cover lifestyle modifications that they can do. And in many patients, we end up talking now, there's a big move towards hormone replacement treatment. So a lot of patients, as you can imagine, a lot of women are interested in how that can play in with the risk. So we cover a lot of things during those appointment times. And then eventually those patients, we come up with a plan together, a plan that works for them in terms of risk reduction. And we tend to follow those patients as they go. Cindy, do you want to talk about what you guys talk about specifically during those appointments?
Yeah, so generally for these appointments, I will review family history and see, who in the family, if any, what we call cascade testing, essentially. So, if there are siblings or parents who haven't had genetic testing, but it would be appropriate and helpful for their own medical care, we do talk about, how to go about doing that and can assist with other family members receiving genetic testing. I always like to let family members know, it's very much a personal decision as to whether to undergo genetic testing or not. And also the timing. It could be just not a good time for that family member to do it. So what's important is that they're aware of that, of the information, and can decide whether it's a good time to undergo genetic testing or not. So we do have resources if people live out of state, if people are in the state of Indiana, we have colleagues here who can meet with those family members to go through that. Also, I think a big question we get is for children, when's a good time to do genetic testing? And again, if for most of the conditions we work with, if screening doesn't start till 25 at the earliest, we really do recommend not testing minor children, for example, for BRCA1 or 2 or Lynch syndrome, unless there's a family history of very early onset cancer. So if the family history includes cancer very early ages, we definitely take that into account. But if not, we do encourage waiting and letting the children become young adults. And that way they can participate in the decision of whether to undergo genetic testing and when would be a good time. Another aspect that could sometimes come into play is medical screening may not start. Maybe we have a 22-year-old young lady at risk for a BRCA2 mutation. She may not be of age to start medical screening, but she might be getting married and planning a family. And so there could be reproductive decisions that are impacted by learning her BRCA2 status. So those are some of the topics that we can talk about with individuals and kind of just help clarify who could benefit, timing, and providing resources.
I should mention, I'm not sure I talked about the clinic itself, Cindy. So this clinic, we see patients once a week. It's on a Wednesday. It's at the IU Schwartz Cancer Center. Um, and we also tend to collect some research information. So we usually ask our patients to answer some questionnaires at the beginning. Um, and we should hopefully have some contact information at the end of this. So if patients are or people are interested to reach out, please feel free to do so. Okay, so we have had a lot of questions come in before the session, but we have, and we'll get to those, at least as many as we can. But I'm getting another question here. So, uh, unknown significance we treat as negative. What if the patient wants to be treated as if they are positive? Cindy, I'm going to let you take this one. More, more
Oh,
aggressive mastectomy and such. And another question is, can you define barred one? So let's talk about if a patient comes in, they have negative or a VUS, and we counsel them. Well, we won't be seeing many of those patients in clinic, but we counsel them, that this is essentially a negative result, but then the response is, well, I want to be treated as though this is positive. So I will let you address this.
really, the way that we would answer that is based on family history. So if the family history looks hereditary, then a negative result, again, doesn't really provide much reassurance. So, if the family history looks negative, or excuse me, family history looks hereditary and you're testing affected individuals and testing is negative or VUS, that just tells me we just don't know enough about our DNA. So if the individual has a significant family history of cancer, or perhaps a personal and family history, and the result is an indeterminate VUS, the VUS part doesn't go into play in terms of decision making. It would be the personal and family history that drives those decisions. Any other thoughts, Dr. Kassem?
Oh, I completely agree here. So, I think I would struggle telling the patient, no, it's negative, and and that's it. So I think taking into consideration family history and then really trying to address why they want to be treated as positive. And also explaining the implications. If we start treating someone as positive, again, we talk about insurance implications, et cetera. If we decide to do additional imaging or procedures, a lot of times these will not get covered by insurance too. So I think a conversation at this point is warranted.
Yeah,
Okay.
I was going to say, just with the caveat again, if it looks hereditary, family history, clearly hereditary disease, the genetic testing doesn't really come into play other than to show we don't know enough about our
We don't know.
DNA.
Yeah. Okay. Do you want
Barred
to just,
one.
yep, go for it.
All right. All right, so BARD1 is just another one of these newer moderate risk genes that we associate um, uh, with cancer. And currently, I'm on the spot and I'm blanking. I'm really, really sorry. It's breast or ovarian, and I am blanking on which gene, which cancer it goes with.
So BARD1 mostly increases risk for breast cancer, and usually that risk is not considered very high. In fact, more on the low and moderate risk. Typically, I don't talk to patients about mastectomy. Again, this is all personalized, so family history, personal experience gets taken into consideration. All right, any other questions? Okay, maybe I can take some of those submitted questions from,
What do you want to do? Insurance coverage? That was a common question.
sure. Yeah, go for
Yeah,
it.
so I know from some of the questions that were sent in, I think some people have heard about laboratories offering so-called free genetic testing. And that's true. Some of the labs will offer what we call cascade testing at no charge. Usually there's a time frame for when that needs to be completed. But I would just reiterate that for third party or common commercial insurance companies, if there's a hereditary mutation in the family, it generally is covered. Um, so in terms of familial testing, that's usually covered. For individuals who are testing based on personal or family history, there are a national set of guidelines that can be referenced that would indicate whether genetic testing should be considered or not. And if an individual meets those criteria, then that could be a supportive aspect for the insurance to cover. And sometimes you can just working with, most of the larger insurance companies are covering it again when it's medically indicated.
All right. We have a few questions, so I'm just sifting through those. So Cindy, I'm not sure, I don't think you touched on this, but if someone is adopted, how do we approach, and we've had a few of those cases in clinic. Can you talk a little bit about how we tend to approach those patients?
Yes, so I think it's really one, we're just sympathetic, of course, to not having that family history information. And you probably are asked that question often every time you go to the doctor's office, what's your family history? The difficulty with doing genetic testing when there is no family history is, again, genetic testing can raise subsequent questions for which we can't answer. So in other words, for like as example, the CHEK2 or ATM mutations, again, these are like the moderate risk genes. And the quantification of risk is actually based on family history. So if you have an unaffected individual and they have a CHEK2 1100 LC, which is the most common mutation, we have data that shows that the risk changes based on the extent of the family history. So one is you could have information you obtain, but we're somewhat limited in what we can in the assessment of what that risk actually is. There's another problem with CHEK2, which is the second most common mutation. Um, Even though the laboratories will they'll call it a low penetrant mutation. So it's a low risk mutation. And we actually don't alter medical care based on that variant being present. But if there's a family history of breast cancer, we would. And then additionally, depending on the test that's ordered, in other words, what genes are analyzed, we can find incidental results in genes that you're not expecting to learn about. So we could be telling someone you have a high risk for gastric cancer or stomach cancer, and it's difficult to know exactly what to do with that information. And likewise, there's some other genes that are considered low cancer risk. So not having family history can make it more difficult to interpret what exactly that mutation means for that individual. So those are just considerations. In terms of actual like logistics, insurance companies generally will not cover genetic testing based on an individual being adopted. So generally, it's going to be a test that's paid for out of pocket. Um, Availability of out-of-pocket testing has been changing over the last couple of years, which actually is a good reminder. Someone wrote in about direct-to-consumer testing, and those direct-to-consumer testing labs where they do genetic testing and the raw data is then sent to a third-party company for interpretation. We would recommend being very cautious about using a process like that. We actually have data that shows that there's a high rate of false positives as well as false negatives. Um, so yeah, I would avoid the direct-to-consumer testing for medical purposes. If you want medical testing, it definitely does need to be done through a medical laboratory.
Okay, I think we just got a good one. Well, another good one. What is the current protocol for pancreatic screening with BRCA1? So, um, I'm glad this question came up. It's very important to note that the guidelines for screening are changing. They are evolving all the time. What I would have counseled a patient last year, including that with pancreatic cancer screening with BRCA1, is different than what I would tell them today. I do take into consideration their family history. That actually plays a huge part. If we are to follow the guidelines for pancreatic cancer screening in a patient with BRCA1, typically, we would want at least a family member, first degree relative, who has been diagnosed with a pancreatic cancer for them to be essentially referred for screening. Having said that, I've had the patient who, for example, had a friend recently get diagnosed or die from pancreatic cancer. You know, those are hard to navigate based on genetics alone, but we do take, like I said, family history and personal history into consideration. Okay, I do want to address one topic that came up, which was how, where Thanksgiving is coming up, people are going to be around family members. So how do we approach, genetic testing or family history of cancer? This can be a very sensitive topic to many people. So Cindy, I don't know if you want to kind of talk about this just a little bit, um, because I think it's really important. It comes up often.
Yes, and feel free to add in if you have helpful suggestions as well. It's, every family has their own dynamics. Some individuals are very private and reluctant or not comfortable sharing private information. Others are an open book. Um, and so it's always important to take into consideration the different, kind of like the dynamics of the family and individuals. Perhaps giving people a heads up that you would like to have a, serious conversation about the family history. Um, for individuals who are undergoing genetic testing, a part of my discussion with people is asking, have you discussed this with your children, if they're adult children, or your siblings or your parents? Um, just from experience, I've found that people who are letting their close relatives know that they're doing genetic testing for cancer, that can help once you have the result, rather than getting the result and then saying, oh, by the way, guess what? Have some information to share. So I think timing is important. I think if you have the opportunity to let people know ahead of time, gauge what their interest is in knowing the results and how much information they want to know. I think also having an open door, kind of an open door policy where you could share with the family, I've had genetic testing. I've learned some important information for the family. Feel free to contact me if you want more details. Um, I've had other families where one family member, usually from the older generation, is kind of like the point person. They're the aunt who stays in contact with everybody. Having that person help with sharing information can be another approach. Um, The one aspect, though, that if you have a family history of a hereditary mutation and you're interested in being tested, is it's extremely important that a copy of that report is provided for review. So, we get referrals quite often in our regular cancer genetics clinic for people who report a family history of a hereditary mutation. And unfortunately, word of mouth is just not the most accurate way to document information. And I've had multiple examples of someone, a patient says, "Oh, my dad has a BRCA2 mutation," and we request a copy of the report, and it's PALB2, or maybe even CHEK2. So if you're looking for more detailed information or accurate information about what family history means, it's those details that are really important. And again, we have ways, sometimes we're able to assist with collecting those records. Um, but it is important that that information be shared so that, family members are able to access accurate information and also have appropriate genetic testing that's accurate. Any other thoughts, Dr. Kassem?
Yeah, I think the only thing I would add is when, again, gauging interest is important with family members when notifying them of a genetic risk, if that is found, but also making sure they relay. So if a person is, identified to have a genetic mutation that increases the risk for cancer, relaying that knowing such a risk in family members helps them essentially undergo more screening, et cetera. So as long I think if we have a background of this can be helpful, and then approaching it as would you like to know, and then going from there would be probably make this a little easier. We've gotten several questions now, Cindy, more individual questions about, for example, we have one. My husband was diagnosed with colon cancer in 2018 without family history. When should our children have their first colonoscopy? So I'm going to talk a little bit here, and then if you want to add, feel free. So I want to make sure we essentially talk about family history versus genetic risk. Those are two separate things. If a person is the first person in the family to get diagnosed with a cancer, depending on what age they were diagnosed with, genetic testing may be offered, and if it was not, something to bring up with your provider. If that individual now is told that this test was positive, that should start a cascade within the eligible family members. So they should essentially seek out genetic risk assessment. If the testing is negative in that person, then family history becomes a priority. And then the children should really, I would say, talk to the provider, let them know that this family history exists. When it comes to colon cancer or breast cancer, actually, many of the cancers, we tend to do at least 5 to 10 years younger than the age of diagnosis in that individual. Cindy, anything else that you want to add to address this?
No, I don't think so.
Okay, let's see. Do we have any more? Oh, yes, thank you. I think we're getting close to the end here. This is just a few resources for anyone who is interested. At the very bottom here is the contact information for the Cancer Predisposition Clinic that we mentioned earlier. Um, I want to thank everyone that's joined us. If you have any more questions, I think we can take maybe a couple of more. So
Yeah,
feel free to send them in. Go ahead, Cindy.
so I was just going to add, if any of you are just interested in more reading or research, this first resource called Force. It's an online support group. It's a reputable group of people, but they have very good information about genetics, and they actually have quite a number of different genes, information for different genes, the moderate risk, the high risk, et cetera. So that can be a good place to go. They also have a lot of good resources on some of these topics we've been talking about in terms of insurance and family communication, things like that. And then if you're into diving into the science, the National Cancer Institute and the National Human Genome Research Institute are good places to go to for more information if you're interested.
Okay, well, one more question came in. I wonder if we can answer this pretty quickly. By we, I mean you. So, has genetic testing changed any over the past 10 years, and has it become better or more detailed?
Uh,
I mean, the short answer is yes, of
yes,
course, right? So,
yes.
go ahead.
Uh, it's changed quite a bit. In terms of cancer genetics, though, the multi-gene panel testing really became available. Again, technology changed in the end of 2013. So probably around 2015, a lot of genetic testing utilized these multi-gene panels. Um, in terms of cancer, that's what we use. If you're familiar with genetic testing in other parts of medicine, like whole genome or whole exome sequencing, at least in terms of cancer genetic testing, we've not utilized those type of technologies because they haven't, the data is not there to show that there's a benefit. But genetic testing definitely has changed. Sometimes people ask me, should I have updated genetic testing? The answer really depends on what was tested to begin with. So if a woman had breast cancer and she had the BRCA1 and 2 testing done in 2012 and hasn't had any since then, there definitely are updates that would be relevant to consider. But if you had a full panel done 2 years ago, there probably is no benefit to testing right now, as long as all the relevant genes were tested.
Okay. Well, I think our time is up. So I just wanted to thank you all for joining us for this month's Simon Says. You can find a recording of today's session and any information about upcoming sessions at cancer.iu.edu/Simon Says. All right. Have a good day, everyone.